I am Dr. Noreen Akmal. I am working as Professor of Obstetrics and Gynaecology at Fatima Jinnah Medical University. This video will explain the procedure of vacuum assisted delivery using Kiwi cup. I have already recorded 2 videos regarding outlet forceps delivery and the use of vacuum cup using the conventional vacuum system. This video will explain the delivery process using the Kiwi cup. Instrumental vaginal delivery, if used in appropriately selected cases, can help in reducing the cesarean section rate. There are various indications for the operative instrumental vaginal delivery. These include maternal indication and fetal indications. Maternal indications are prolonged second stage of labor. If mother is suffering from some medical disorder which prohibit maternal pushing and Valsalva maneuver, then the second stage of labor should be shortened by using instrumental vaginal delivery and if the mother is exhausted. The fetal indications include suspected fetal compromise, and this compromise is evident by abnormal fetal heart rate tracing, by abnormal results of the fetal scalp blood sampling, and by passage of meconium. This is Kiwi vacuum delivery system. It consists of 3 parts. This is the palm pump, this is the flexible stem, and this is the Kiwi Omni cup. Palm pump consists of 3 parts. Number 1 is the handheld vacuum device. This will create the vacuum. This is the vacuum indicator which indicates the pressure of the vacuum which has been created, and if you see, this is the release button. If we press this button, the vacuum will be released. Now this is the flexible tubing. You can see that this is flexible and it has markings at 6 cm and at 11 cm. The traditional cups which are used for the delivery, they have a rigid stem, and this stem is flexible, you can see. And this cup, this is the cup. Third part is the cup. This is Omni Kiwi cup. This is a low profile cup, and you can see there is a groove on the back of the cup and there is a foam filter on the inner side of the cup. And it is also clear that the outer circumference of this part is smaller than the inner circumference of the cup. So when the cup is applied to the fetal scalp, in order to create the vacuum, it creates an artificial capet, and this is fixed on this part, and this is known as the chignon. And this capet provides a firm grip of the vacuum on the fetal scalp, and it prevents the detachment of the cup from the fetal scalp. As I told you that the stem of this Kiwi cup is flexible and this is a rigid stem. So if the baby is presenting in an occipito-anterior position, I can use this cup, and this cup can be applied easily on the flexion point. But if the baby is presenting in an occipito-posterior position, you can see that the flexion point is behind posteriorly in the pelvis, and it is very difficult to maneuver a cup with a rigid stem over the flexion point. The beauty of this cup is that this system is that it has got a flexible stem. So I can easily maneuver my cup over the flexion point even if it is present posteriorly, and application of the cup to the flexion point is very important, because if the cup is applied to the flexion point and when we apply traction, it is going to encourage flexion of the fetal head, and we all know that flexion of the fetal head leads to a smaller diameter is going to present to the pelvis, and the delivery process will be helped. But if it is applied not at the flexion point, it is applied anteriorly, it is not going to help flexion, but it is going to increase the extension, and a larger diameter is going to present to the pelvis, and the delivery will be obstructed, or it will be a difficult delivery. So this flexible stem is going to help us in application. It can be used in the occipito-anterior as well as in the occipito-posterior position easily. Whenever this device is used, certain prerequisites must be fulfilled. There must be an appropriate indication. which I have already explained. Informed consent should be obtained from the patient, and the patient should be explained about the use of this device. And the operator who is using this instrument should be experienced in the use of instrument. An appropriate analgesia should be provided to the patient. Without analgesia, this instrument should not be used. Gestational age of the fetus should be more than 36 weeks. Between 32 to 36 weeks, vacuum can be applied by the experienced operator with caution. There should be facilities for the neonatal resuscitation, and the pediatrician should be available, and there should be facilities for the cesarean section in case the vacuum delivery fails. Fetal head must be engaged. By engagement we means that the biparietal diameter of the head has crossed the pelvic brim and the vertex should be at plus station. Pelvis must be adequate. There should not be any evidence of cephalopelvic disproportion. Uterus must be contracting. That means the uterine contractions must be adequate. Bladder should be empty. Cervix should be fully dilated. Membranes should be ruptured. If caput is present, it should not be more than 2+. If molding is present, it should not be more than 2+. And last but not the least, the operator should have willingness to abandon the procedure in case of failure or in case any complication arises. Vacuum delivery should be avoided if the patient does not give the consent, so we cannot proceed with the vacuum delivery. If the operator is not experienced in the use of this device, so this device should not be used. If the gestational age of the baby is less than 32 weeks, this instrument should not be used. If the gestational age is less than 32 weeks. If there is any evidence of cephalopelvic disproportion, that means either the pelvis is small or the baby is big, and we are anticipating cephalopelvic disproportion, then this instrumental delivery should not be used. If there is any malpresentation, that it's a face presentation, it's a breech presentation, it's a bra presentation, this instrument should not be used. If the baby is suffering from some bleeding diathesis, this should not be used. And if the baby is supposed to be suffering from some disorder in which there is more chances of fracture of the bones like osteogenesis imperfecta, then again this instrument should not be used. Complications which can occur in the baby with the use of this instrument. The most common is formation of Shannon, which is actually an artificial caput. It usually disappears within a few hours. Other complications which can occur are lacerations and abrasions on the fetal scalp, formation of capsule hematoma, formation of the subgaleal hematoma. Subgaleal hematoma is quite a serious complication, and pediatrician should observe the baby for at least 24 hours in the nursery in order to early detect this complication. Other complications which can occur in the baby are hemorrhages which can occur in the subconjunctival area, retinal hemorrhages and intracranial hemorrhages. If the hematoma is formed, the baby is likely to suffer from neonatal jaundice. Maternal complications associated with the use of this instrument. If we compare vacuum with the forceps, vacuum is supposed to be more friendly for the mother because complications in the mother are less if the vacuum is used as compared to the forceps. The complications which can occur in the mother, they include perineal tear, vaginal tear and cervical tears. If they are present, they should be tiered immediately if required. Other problems which can occur after the use of vacuum or any instrumental delivery is urinary retention. So the care of the bladder should be taken. And if the delivery is traumatic, mother might suffer from post-traumatic stress disorder and she may require psychiatric or psychological support. Application of the Kiwi vacuum cup is described in 5 steps. Step 1 is identification of the flexion point and measurement of the cup insertion distance. In order to identify the flexion point, we should know certain landmarks. This is the sagittal suture, this is the posterior fontanelle, and flexion point is 3 centimeter in front of the posterior fontanelle. This is very important landmark because the center of the cup should be applied to the flexion point. And if the cup is applied to this point, when we are going to apply the traction, this traction is going to increase the flexion of the fetal head and a smaller diameter is going to present to the pelvis. If we do not apply it at the right place, if we apply it anteriorly and it is not applied on the flexion point, when the traction will be applied, extension of the fetal head will be extension of the fetal head will occur and a larger diameter is going to present, so that delivery will become difficult. Similarly, if the center of the cup is not applied on the flexion point and it is applied laterally, that is known as the paramedian application, and if it is applied like this, and if the traction is applied, so one point when the traction is applied, it is likely to pop off. And the second point, when the traction will be applied, it is going to increase asynclitism, and asynclitism will hinder the process of normal delivery. So first of all, a vaginal examination should be done, and it should be made sure that all the prerequisites of vacuum application, they have been fulfilled. Then I am identifying the posterior fontanelle and the sagittal suture, and I have identified the median flexion point, which is 3 centimeter in front of the posterior fontanelle on the sagittal suture in the midline. And then I am going to mark the point where the back of my middle finger is touching the posterior foreskin. So this is the point. So as I have already told you that the distance between the tip of the middle finger and the proximal interphalangeal joint is approximately 5 centimeter. So my finger was touching the posterior foreskin here. So the cup insertion distance is approximately 6 centimeter, and that is how we measure the cup insertion distance. Step 2 is to hold and insert the cup. The cup should be held in the hand which will be used for the pulling, and you can see that on this cup, this is the back side of the cup, there is a groove on the back side of the cup. The thumb should be placed on the groove and the index finger should be placed on the edge of the cup, and the cup should be inserted like this vertically so that the groove is at 9 o'clock position. So I am going to insert the cup like this. I am using the 2 fingers of the non-pulling hand, and I will retract the perineum. I am going to insert the cup like this, and then I am going to place the cup over the fetal scalp, and I am going to move it so that the groove on the cup is now at 12 o'clock position. This completes the second step, that is insertion of the cup. Step 3 is to maneuver the cup so that the center of the cup lies over the flexion point, and the distance which we measured in this case was 6 centimeter. That is the distance from the tip of my middle finger to the point where my finger touch the posterior foreskin, and as you can see, it is approximately at 5 centimeter, and the mark on the stem on the 6 centimeter is here. So I am going to push the cup slightly upward so that it is positioned exactly over the flexion point, and now you can see that this point is at the foreskin, and now we are sure that the cup is at the flexion point in the normal position, and I am going to stabilize the cup with my this hand. As I have already explained, that correct placement of the cup is that the center of the cup should be at the flexion point, which is 3 centimeter in front of the posterior fontanelle, and the sagittal suture should be in the middle of the cup, and margin of the cup should be 3 centimeter away from the anterior fontanelle, and there should not be any maternal tissue in between the cup and the fetal scalp. So I am going to do a vaginal examination, and I am going to ensure that sagittal suture is in the middle of the cup, and anterior fontanelle is 3 centimeter away from the margin of the cup, and there is no maternal tissue entrapped in between the fetal scalp and the cup. Step 4 is to create the vacuum. As you can see on this pump that there are markings yellow, green and red. Initially, when we will create the vacuum, I will increase the pressure up till the yellow mark. Once I am sure that the cup is accurately placed and there is no maternal tissue entrapped between the cup and the fetal scalp, so I am going to increase the pressure to the green zone. That is, the pressure can be kept between 450 to 600 millimeter of mercury. Pressure should never be increased more than 620 millimeter of mercury, that we should not enter in the red zone, because if the pressure is increased more, then the chances of fetal complications, they are increased. So I am stabilizing the cup with my one hand and I am going to create the vacuum. Initially, I have increased the pressure to 100 millimeter of mercury and I am doing a vaginal examination to make sure that no maternal tissue is entrapped between the cup and the fetal scalp. As I am sure about this, now I am going to increase the pressure up to 600 millimeter of mercury, that is the end of the green zone. Now the vacuum has been created. Step 5 is to apply traction. Traction should always be applied during a maternal uterine contraction along with the maternal expulsive efforts. Traction should be applied at right angle to the cup. It should always be a sustained traction during a uterine contraction. It should not be intermittent. And traction should follow, direction of traction should follow the axis of the birth canal. And we should use the thumb and the finger technique. And this is that I am going to apply the thumb on the back of the cup and the index finger on the scalp. The thumb is going to provide counter traction to the cup while I am applying the traction, and this will prevent the dislodgement of the cup, whereas the index finger is going to monitor the descent of the fetal head. So I am going to introduce my two hands, my index finger and the thumb in the vagina. With the thumb, I am pressing the cup and index finger is monitoring the descent of the fetal head. It is on the fetal scalp. With the maternal uterine contraction and maternal expulsive effort, I am going to apply traction during a uterine contraction. The traction will follow, it is initially downwards, it is following the axis of the birth canal. When the baby head is about, at the time of crowning, the assistant should support the perineum in order to avoid perineal trauma, and episiotomy should only be made if indicated. So my thumb, as you can see, and now the baby head is about to deliver and the baby head has delivered. You can see the application of the cup is at the flexion point. It is in the cup, is sagittal suture is passing through the center of the cup and the cup is properly applied. Once the baby head has delivered, we should release the pressure and remove the cup. And this cup, I would like to mention, is meant for single use. It should be discarded and disposed of. It should not be used on the other patients. When should we stop the procedure? The procedure should be stopped if with each pull there is no successive descent of the fetal head. If after 3 consecutive pulls the delivery is not imminent, the procedure should be stopped. If the vacuum cup detaches twice during the procedure, this is an indication that the procedure should be abandoned. And in case the application time of the vacuum cup to the fetal scalp has exceeded 20 minutes and the delivery is not imminent, this is also an indication that this procedure should be stopped. After delivery of the head, the pressure should be released by pressing this button. As you can see, the cup should be removed and the delivery of the rest of the baby should be proceeded in the normal way. Umbilical cord should be cut and the baby should be handed over to the pediatrician. The baby should be examined by the pediatrician and should be kept under observation for 24 hours. Post-procedure care. Debriefing of the parent should be done. They should be explained why it was necessary to use the instrument and is there any complication which has occurred, and they should be explained about that complication. Patient should be given appropriate, adequate analgesia. Antibiotic cover should be given. She should be told about the bladder problems which can occur, and bladder care is part of post-procedure care. If delivery was traumatic, she may require psychological support, and that should be provided to the patient. At the time of the discharge, the patient should be given a discharge slip which should have the detailed notes of the procedure, of any complication if it occurred, and any instructions about the use of medications. They should be written on the discharge slip. She should also be instructed about breastfeeding, about vaccination of the newborn, and for contraception in the future. I would like to give this message that if instrumental delivery is done by appropriately trained persons in selected cases, it can help us in reducing the rising cesarean section rate in our country. Thank you.